Let us invite Dr. Lekshmi, Assistant Professor, Government Medical College, Kottayam. Her topic is Essentials of Tonometry.
Good morning. Thank you, madam, for this opportunity. So I'll be dealing with some essential points in tonometry. So intraocular pressure, as you know, is a fine-tuned equilibrium between the production of aqueous, the drainage of aqueous, and the episcleral venous pressure. The normal IOP is generally considered between 10 to 21, but remember that it is a dynamic measurement, just like a heart rate or blood pressure. And various studies have shown that half of all individuals with open-angle glaucomas can have IOPs below 21. But still, we need to measure the IOP because it is the only significantly modifiable risk factor for glaucoma, which affects both the onset as well as progression of glaucoma. Now, the quantitative assessment of intraocular pressure using a calibrated instrument is tonometry. Now, depending on the mechanism, various types of tonometers are available. The prototype of indentation is your Schiot's tonometer, which is still widely being used in our part of the world. The main problem with Schiot's is that it is influenced by ocular rigidity. So in conditions when the rigidity is low, like in a myope, you may underestimate the IOP. Now, the applanation tonometer, that is mainly Goldman applanation tonometer, which is a fixed area variable force tonometer. It is the most commonly used tonometer worldwide and considered as a gold standard based on the invert Fick principle, and the applanating diameter is 3.06 millimeters. Now, as you all know, it is a slit lamp mounted instrument. You have a biprism, which is the applanating area. Then there is a housing which has the weights and the adjustment knob to adjust the force that you need to apply. Now, regarding the procedure, the points to remember are, before you start, always make sure that the prism is clean. Then the blue filter should be applied with maximum light intensity, fully open. Magnification should be less at 10x. And start with a tension of 1 gram. Patient should be seated comfortably, aware of the procedure, cooperative, and you look through the eyepiece. It's a uniocular measurement, and what you see will be two semicircular Myers, which are equal size. So the point is we have to make it, we have to turn the tension knob so that the Myers just get approximated. So these, when the inner edges of the Myers get approximated, it is the end point of applanation. You can note down the reading, multiply it by 10, also note down the time. So if you see the Myers too far apart, that means you need to increase the force. If they've already crossed, that means you need to reduce the force. Now, error in Goldman mainly is due to the effect of corneal thickness. As you know, a thick cornea means you need more force to applanate it. So you may overestimate. And a thin cornea or an edematous cornea, you need less force to applanate, and you may underestimate it. Various correction formulae are there, but none are universally accepted. But you should keep in mind that if the cornea is thin, the optic nerve is susceptible, even if the IOP is in the normal range. Then corneal astigmatism, more than 4 diopters can affect your Goldman readings. Then understaining, too much of dye or too less of dye, asymmetry of Myers, irregular corneas, patient factors, breath holding, valsalva, tight collars, all this can affect. And of course, a poorly calibrated instrument. Always calibrate the tonometer at least once in 3 months or according to its use. Now, certain other tonometers which are also widely used, Perkins, it is same as Goldman, only thing is it is handheld and portable, so you can use in children and also people who can't be seated on the slit lamp. Then Tonopen also uses the Makema principle, but it is handheld, portable, useful in irregular and edematous corneas and children. Then NCT is there in all ophthalmology clinics, but remember that you can use it as a screening tool, but the accuracy decreases with high IOPs. Then Pascal's DCT is a slit lamp mounted instrument using contour matching. So it is less affected by corneal thickness and properties. So you can use it in thin corneas. Then rebound tonometer is very popular in the Western world. It is handheld, portable with small area of applanation, no topical anesthesia. You can use it for home tonometry even. Then transpalpebral tonometers are also available where we measure the IOP through the eyelids, but readings are not that accurate. Then 24-hour monitoring devices, triggerfish, contact lens, and also implantable materials, these are all being researched. Now, in special situations like in children, eye care rebound, if available, is the best option, or else Tonopen, Perkins, or in an older child, Goldman. Then also effective anesthetics. All anesthetics usually reduce the IOP, except ketamine and succinylcholine, which may increase the IOP. Therefore, in irregular cornea, edematous cornea, going for Tonopen pneumotonometers, thin cornea, post-LASIK eyes, and all Pascal's DCT is said to be ideal. Then in conclusion, I would like to say that in spite of having so many different tonometers, for the routine diagnosis and management and follow-up of a person with glaucoma, Goldman applanation tonometry is still considered to be the ideal one. Thank you.
Thank you, Lekshmi, for your informative and elaborative talk about IOP. To start a therapy for glaucoma, 3 IOP readings 3 times a day is preferable to start a therapy. But the ideal would be the diurnal IOP measurements. And if the IOP is more than 30 millimeter of mercury, reconfirm once again and start therapy. So as she said, the Goldman applanation tonometry is the gold standard. But the presence of IOP does not equate the diagnosis of glaucoma. Conversely, decreased IOP or normal IOP does not exclude the diagnosis of glaucoma.